So my name is Dr. Steve Tucker, and I'm going to present to you today about some updates in breast cancer, some tips and tricks, and how we're personalizing breast cancer, treating it individually as opposed to looking at it as one disease, seeing it as multiple diseases. So it's important that you know a little bit about me. I originally was trained as a cancer specialist, and a very conventional cancer specialist, like all of the other cancer doctors I know. So we learned about things like anatomy and x-rays and chemotherapy, and I've done that for years to treat breast cancer. But at a certain point, I started thinking about preventing breast cancer, that maybe we could do more with prevention than we can actually do with treatment. And so now I spend a lot of my time thinking about how lifestyle can impact not only the prevention of cancer coming back, but how can lifestyle prevent cancer in the first place. This is the hardest part of my talk. This is the scary part. I have to make you aware of the numbers, of the problems that we all face, whether in Vietnam or Singapore where I practice, or in the US where I came from. 14 million cases of cancer per year in the world, 8 million deaths. Vietnam has approximately 90 million people. Breast cancer is the #1 cause of death in women. It is the #1 cause of cancer in women in Vietnam. Cancer statistics. In Vietnam, there are 125,000 new cases of cancer every year, and that number is probably underreported. There are also 95,000 deaths from cancer, and so the ratio of the number of new cases to deaths is very high. So Vietnam's working to do a better job to reduce the death rate. Also, breast cancer cases in Vietnam have been increasing significantly. So in the year 2000, there were just maybe 6,000 cases reported. And now you're up to nearly 15,000 cases every year. And that's still underreported. And compare breast cancer to other common cancers in Vietnam. 11,000 in 2012, but all the lung cases, liver, cervix, colon. And the two colors, the first color is the number of new cases. And the second, the purple, is the number of deaths. So with breast cancer, most women are still going to be cured, which means we have to talk about prevention of the breast cancer from coming back. Also, in Vietnam, there's a difference in the number of breast cancer cases based on where you live. There are more cases in Hanoi and fewer cases in Ho Chi Minh. And what it really means is that there's a problem in reporting, and there may be some differences in the environment. But overall, you can still see it's much more common in the major cities. Most of the cases are under the age of 50. It's a younger population that gets breast cancer. Also, if you look at all of Vietnam, most of the cases are what we call early. But if you look at just the big hospitals, then it's 50% early and 50% late or advanced disease. That's probably a reflection of people from rural villages going to the major hospitals. But let's get to the background. Let's get to the root, because I'm going to talk about this more and more. It's supposed to be a cancer talk today, a talk about breast cancer. But you can't talk about cancer without talking about an epidemic of obesity. And Vietnam, as healthy as it has been, is becoming very fat. Obesity in Vietnam used to be 5% around 1980. And now, more than 12% of Vietnam is obese. Not just overweight, but obese. And that obesity leads to diabetes. The two together, obesity and diabetes, are huge drivers of disease. They very specifically drive breast cancer, colon cancer, prostate cancers. They also drive things like heart attacks and stroke and fatty liver disease. So understanding diabetes and obesity and the risk that they are for breast cancer is an important story that I'll keep coming back to. Lastly, survival rates. So we need to look at, if you get diagnosed, what are the chances that you're going to make it? What are the chances that you're cured or whether the cancer comes back? And 3 locations. Right now in Vietnam, overall, all cancers, not just breast, it's a 24% survival rate. That's something we need to improve on. If you look at the whole world, it approaches 50%, 42. And in the United States, 65% of everyone diagnosed with cancer will be alive and well 5 years later. So it's important that we get early diagnosis and screening more active in Vietnam to improve the survival rate. So that's the hard part of the talk. Those are the scary numbers. Now let me show you and teach you how we make a diagnosis and decide how to treat and then personalize it. So as most of you might be familiar, to diagnose breast cancer is usually a mammogram. The patient may feel a lump in their breast, or they may just go for a screening mammogram. And a mammogram is done, and maybe an ultrasound can be done. For younger women, we often do an MRI of the breast, which is even more precise. And if you have high risk, like family members have had breast cancer, an MRI is the right tool to use. But then, if there is something suspicious, a biopsy is done. A small piece of the tissue is taken out by a surgeon, and then it's analyzed in a laboratory by the pathologist. You have to look under the microscope, and it's the pathologist who really makes the decision to say, this is cancer or not. With that information, you come speak with me, and we talk about what's the best strategy to cure this newly found breast cancer. So what do I do? What are the tools that I'm going to talk to you about to cure breast cancer? And again, I'll keep this simple. Surgery. So we can operate and remove the tumor. If the tumor's in the breast and only in the breast, then surgery is the best thing we can do. We can also do radiation, usually just to clean up the area around the surgery. We wouldn't do radiation alone in most cases. We will also use things like chemotherapy to get rid of any microscopic cells, and hormone therapies because the cancer could be sensitive to female hormones, and sometimes genetic or molecular targeted therapy, something that's very modern that's targeted on the unique characteristics of your breast tumor. How do I put that all together? It's actually very simple. Treating breast cancer has 2 parts. There's what we call local therapy, which means taking care of the problem in the breast, just in that local area, and taking care of any lymph nodes that might be in the area. Small immune pockets in the armpit or on the shoulder. That's how we cure breast cancer initially. We will use surgery or surgery and radiation together. Surgery could be a mastectomy, a bigger operation, and it's just as good as a smaller operation plus the radiation. So we call that breast conservation. Try to retain as much healthy tissue as possible. That's local therapy. However, my job is to try to figure out, have microscopic cells left the breast or the lymph nodes even before the operation. And so now we have to talk about whole body therapy or systemic therapy, because depending upon how big the tumor is or if the lymph nodes are involved, the cancer could come back in the lungs. It could come back in the liver. It could come back in the bones, or it could even come back in the brain. And I think it's an unusual phrase to say that the cancer comes back. because if it was gone, it couldn't come back. It means it never left. And that's why systemic therapy is so important, because when cancer comes back, it means that it never left. And only systemic therapy, the hormones or the chemo or the targeted therapies, are going to be the ones that can mop up, clean up those microscopic cells that we can't see at the time of surgery. So again, hormones or combinations of hormones and chemo, or hormones, chemo, and targeted therapy. Usually for 5 years, chemo tends to be for 3 months, maybe 4, but the hormone part could be for 5 years, and for younger women, even 10. That's the general approach. That's the approach every oncologist knows. Combinations of surgery and radiation, followed by pills and shots and chemo to do local and systemic therapy. The thing is, everybody is different, and tumors are different. Breast cancer is not one disease. We are all different people. We are men and women. We are long hair and short hair. We are tall and short. We are so many different kinds of people, and cancers are very different too, even if they all start in the same place. So breast cancer might be the origin, but under the microscope, they look very different. It is not one disease. And this looks a little technical, but here's an example of the 4 most common kinds of breast cancer, or subtypes. And we really just subtype it based on 2 features. One is the hormones. Is there a hormone marker on the surface? And then there's a genetic marker called HER2 or HER2. And so some patients are positive, negative hormones and HER2. Others are positive, positive. They have both markers. Some people have a flip, are negative, positive. And the last group has nothing, or what we call triple negative. And so these 4 different groups, type A, type B, HER2, and triple negative or basal, they're really 4 different diseases. Think of them as automobiles. They're all identical Toyotas or Hondas or Teslas, but underneath the hood, the engine is completely different. And when you look at the outcomes, meaning how well patients do 5 years later, the subtype of breast cancer makes a difference. People with the type A's are very, very likely to be cured long term. But the ones that are triple negative have a much, much higher rate of failure, of relapse, and death from breast cancer. So subtypes of breast cancer are important in predicting the future, and it's important in choosing the right medicine to do a better job. And that's personalizing the treatment based upon the unique characteristics of the tumor. So my job is really a crystal ball. I need to predict the future. Is this patient going to relapse? How would I tell? What's the subtype, the size of the tumor, or the lymph nodes involved? And we're good at that. But like I've been saying, I'm not going to treat people anymore like a standard curve. I don't want to just give people the average. I'm interested in giving them the best, what is unique, and personalizing the treatment to the personalization of the tumor. And that's not a standard distribution curve. That's what we call a long tail. And while maybe 80% of the breast cancers are like this, another 20% are completely unique. And so this kind of long tail distribution is how you begin to think we're all very different. It's sort of the way Amazon works when you buy things online. That if you like Star Wars, they might ask you to buy Star Trek. If you like cooking, they'll say, well, these people also bought things for baking. And so we are all individually very different, and so are the tumors. Here's an example. This is exactly how we try to predict the future. Here's a woman, age 45. She's got the hormone markers. Her tumor was 1.5 centimeters. She doesn't have the HER2 marker, and she had one lymph node in the armpit. And the first pathologist said, under the microscope, it looks okay. It's not so terrible. The pathologist said it's grade 1. And based on that information, I can say if my patient does surgery and then runs away, about 70% of the time they're going to be cured. And you can see how many would relapse. And if I add hormone therapy, I save a few more lives. And if I add hormones and chemo, I save even more lives. But what if it's the exact same case, but the pathologist now says it's not grade 1, it's grade 3. It's actually more aggressive. That's an opinion. That's the pathologist looking under the microscope and saying, you're very attractive. Someone else saying, not the prettiest one I've ever seen. That's the difference. And so in this case, where only the grade changed, these red and yellow boxes changed significantly. Let me put it side by side. The first case, we said that there's ultimately going to be a 9% chance that the cancer will come back. But in the second case, it's double, an 18% chance. And that's all based on one person's opinion. Not on science, not on fact. It's based on just me looking at something and saying, this little area where I'm looking looks bad, where there could be other areas. And fortunately, we can do a better job than that. And the way we do that is with a test. In this case, it's a DNA test on the tumor. So it's looking under the hood of the car and telling what is the engine driving this cancer. And that test is called an Oncotype DX. It's on the breast cancer tissue in the laboratory, and it splits my patients into 3 groups: low risk, intermediate risk, and high risk, because they're all unique cancers and unique people. They're not all the same. Most women, in fact, when you use this test, don't even need chemotherapy. So some still do, but now instead of giving people an average benefit, I'm going to show you how the women who get chemo in our practice get more benefit than expected. And at the same time, the women who don't need chemo can avoid unnecessary side effects. This is what the report actually looks like. And if you can see here, there's really 2 curves. And these curves, they're all women with early breast cancer, but half of them got a hormone pill for 5 years, and the other half had gotten a hormone pill and chemo, just a few months of chemo. But if you split the patients down by the test result, by their number, the recurrence score, you can see that the patients in the low and the intermediate risk group, they don't benefit from chemo. This is the chemo line. This group, hormones versus chemo, same. This group looks a little bit separated, but statistically, same. But this group out here, huge difference. A very big difference between the patients who got chemo and who didn't. So instead of treating everyone the same, I only give chemo to the patients who fall on that end of the curve, and they get more benefit than we would typically expect. And the women at the other end, I can avoid chemo. And that's a genetic test on the tumor itself, on the breast cancer. We talk a lot about genetics and DNA testing in my practice. It's something that cancer doctors have become very good at. But it's not always about the genetics of the tumor. Sometimes it's about the genetics of the patient. Maybe you come from a family where lots of people get cancer or breast cancer. When we talk about genetics, sometimes people get anxious. They're worried that their DNA is the future. DNA is not a test. DNA is not destiny. It's not going to stop you from being a doctor, a lawyer, a banker, or a fireman. DNA is a resource. It's information for you to make better decisions in life. And your DNA can be easily measured. These are just some of the companies in the US that I work with to do genetic analysis on breast cancer patients. And here's one tool that we can use. This is called a genetic risk score. It's an inexpensive tool that doesn't even look at the gene itself, but just different markers. And if you have a lot of markers that are high risk, you wind up on one curve, and you might have above average risk. Or if you don't have any of the markers, you'll be on the bottom curve and have lower risk. And we can use this now to help determine who needs a mammogram and who needs an MRI. So instead of everyone just getting mammograms at 40 or 45, some people who are at very high risk at a younger age, they would benefit from an MRI. And women have dense breast tissue before age 40. And that limits the utility, the benefit of an ultrasound and a mammogram. So those patients may be directed to MRI. It's really about screening at a personal level. So it's not just treating the tumor personalization, but sometimes the screening, how do we prevent disease, needs to be personalized as well. If no one in your family has ever had cancer, and you have a big family and they all live to 100, maybe you don't need to do a mammogram at 45, although you should be offered one, but you can also try to prevent the harms of overscreening. Here's a famous family history, a pedigree. And this is the most famous breast cancer gene called BRCA. There's a type 1 and a type 2. And these are called the breast cancer genes, or hereditary breast and ovarian cancer. And they're very straightforward. I often don't even need to do genetics if somebody tells me the right story. You have to spend time with your doctor. They have to ask about at least you, your parents, your grandparents, maybe your children, 4 generations to get a good understanding of your family history. In a BRCA1 patient, it's early onset breast and ovarian cancer. This is exactly the pedigree that Angelina Jolie, the actress, has, where breast cancer at an early age, grandma with ovarian cancer, fatal, more ovarian cancer, more early breast cancer. And then the type 2 version is similar, but at a little bit older onset, and it includes some cases of prostate cancer and even pancreas cancer. But that kind of information is all from you knowing your doctor, from you and me having a conversation about your health. But these aren't the only genes. This is a patient of mine, and her pedigree has lots of breast cancer. All those red circles are cases of breast cancer. And the family was genetically tested for the famous breast cancer gene, BRCA1 and 2. And in fact, no one here had it, this being my patient. And so when she got breast cancer, another doctor told her that she didn't have to worry about genetics. But I said, maybe your mom was tested at a time when we could only test for BRCA. And so I tested the patient, and indeed she had a completely different and common genetic variation, mutation, that causes breast cancer in the whole family. And we now measure all of those easily with a single blood test or even saliva. We don't even have to draw blood. And we look at more than just BRCA1 and BRCA2. What we look at, and here's an example from Singapore, 220 women with breast cancer, breast or ovarian. Of those 220 women, 66 were found to have a gene that probably causes their cancer. 66, that's 30%. But the famous BRCA1 and 2, they only account for half of those genes. My patient is in here way over there, BRIP1. And so these are other important genes, and they're just as easy to find today from saliva or blood, and can help determine how we're going to treat and how we're going to prevent, and what are we going to tell your children, your daughters, your mothers, your sisters. And this slide shows that more and more people need to be tested. Now that testing is less expensive and better quality, these are the guidelines and how many people we would find in the US. all patients with breast cancer under the age 45 should be offered genetic testing. All breast cancer patients under the age of 60 with the dangerous triple-negative breast cancer should be offered genetics. All ovarians and uterine cancers should be offered genetics, and all colon cancers should be offered genetic testing, and family members. Thank you for your attention.